is Saurav. Saurav is a sign language interpreter and a member of the Association of Sign Language Interpreters. He has been a professional interpreter since 2015. Saurav will be joined by Rajesh. Maybe Rajesh can just wave like me from his screen. Rajesh is also a member of the Association of Sign Language Interpreters of India, and he has done this service for various organizations. So we're very grateful to have both Saurav and Rajesh joining us today to ensure inclusion in this event about social participation for universal health coverage. Today we have a great lineup of presentations and conversation for you. We will begin with a presentation that shows findings from a research study using a very interesting set of methods where we try to understand the history of social participation for health in this country, in India, where you're being hosted from. And so we have some work that's happened on that at the national level and then also at the state level. So we'll be joined by colleagues from the George Institute for Global Health who will present about this. Following that, we will have a fireside chat with some eminent and very inspiring colleagues from around the world who have been working in this space around social participation, around health for all, and around social inclusion in general. And that fireside chat will be hosted by Professor David Perez, again from the George. So like I said, it's an honor for us to have you all here. I think what we'll do is, now that people are more or less in the room, please keep coming in. I will start with some introductions. So I'd like to start by introducing our first speaker, Missimi Kakoti, who is a research officer at the George Institute for Global Health. She's currently working in a number of areas and has worked for a number of teams at the George. And her interests are at the intersection of gender, rights, and equity in health policy and in health systems. She will be talking to you about some of the research she has been doing on social participation for health in India. So now I'll ask Missimi to please share her screen and make her first presentation. Over to you, Missimi.
Thanks, David. Thanks for the introduction. I'll just share my screen. Let's start share. 1 second. Oops. Sorry. Just, okay. I'm not able to share my screen. Sarika, could you please share my presentation if it's possible?
Sure, I'll do that.
Thank you so much. Yeah, thanks, Sarika. If you could put it on a slideshow mode. It's the button below. Yeah. Yeah. Thank you. Hi, everyone. So with the help of a few slides, I would like to take you through the study that we did to document India's experience of institutionalizing social participation for health, more specifically as part of the National Rural Health Mission. And the name of the project was Community Action for Health in India. If you could move to the next slide. Just click on just one of the buttons, like left, right. Thank you. So with a bit of a background to the project, India has a very rich history of social participation and mobilization. for health, but these experiences have not been the documentation of these experiences have been very limited, and these experiences also have a lot of lessons for the world. So we focused on documenting some of these experiences, specifically focusing on the community action for health models that were institutionalized and operationalized under the National Rural Health Mission. And by way of that are the specific models, mean the communitization and the community-based monitoring and planning frameworks as referred in the policy NRHM. And our aim was to create a historical record of these activities and the activities related to communitization and community-based monitoring and planning mechanisms under NRHM. And the approach that we took was of co-production, and that is we wanted to involve and hear directly from the actors who had participated in design, implementation, and development of these frameworks and structures and models. And the method that we used for this was the witness seminars. It's a oral history methodology that was developed by Tilly Tenzi in 1990s. And in this method, a group of invited participants, they discuss, debate, agree or disagree on themes related to certain event in history, and they draw on their reminiscences and they share their perspectives, especially events that they have been directly involved with and have participated in very closely. And the primary output of these seminars is an annotated report, which is sort of annotated, and it represents it has the conversations of the seminars directly, and also it represents the voices of the participants directly. And Sarika, if you could move to the next slide. Thank you. So these are a few examples of witness seminars that have been held in the past. As you can see, the first one is on health policy reform in New Zealand. And this method has also been used to document the HIV movement. And then in India, the Sathi Sehat organization held 2 witness seminars covering the theme of private health care sector. And at the end, you'll see this is a paper which is based on a series of witness seminars that will help to capture the emergence of community health worker program in South Africa. Sarika, if you could click just thrice, I think it should appear. Yeah, so now I'll just cover how we actually adopted this method for our study. So the first phase was the preparatory phase. So we began with preparing a concept note and preparing a timeline to focus on, for example, what should be the scope of the study that we want to do. And so we started with the launch period of the National Rural Health Mission, which was 2005. That's when the program was launched. And also we wanted to cover the anteceding and succeeding events. After that, we wanted to identify witnesses for the seminar, and we referred to government documentations, and we also reached out to our network and also then again there was this and succeedingly they also referred to a few people that we could reach out to for inviting them to the seminars. And these witnesses, they involve administrative officials, policymakers, advisors, civil society members, and academicians. And then we also selected the chairperson. And then this was followed by meetings with the witnesses. They helped us frame the guiding questions for the seminars, and they also helped us with defining the themes. And then we formulated the seminars around the themes of
I'm sorry, we have to request the participants to kindly mute their mic.
Okay, thank you. And the last theme was on evaluation and impact. And And the last stage of this phase was getting the logistics ready, like sending the participant information sheet to the participants, and also the guiding questions to help them with the bearings for the session. And also, and then we sequence the witnesses based on, the questions that we were going to have at the seminar to steer the conversation. And that was done by the chairperson. Sarika, if you could click next, just one. Thank you. Yes, so next is the seminar phase. It was held on Zoom because of the pandemic restrictions, and they were of 1.5 to 2 hours each. So there were 2 witness seminars and 4 supplementary in-depth interviews that we conducted. There were 9 participants in the first witness seminar, 5 in the second, and 3 IDIs were conducted with witnesses from the seminars who wished to elaborate more on their sections. And there was one in-depth interview we had with a participant who was not able to attend the seminar. And the last phase is the transcript and report phase. Here we transcribe all the recordings from the seminar and the in-depth interviews. Then we send it out to the witnesses and participants of the in-depth interviews for a member checking. That is, they at this stage of the process, they can edit and make changes to their verbatim as they feel comfortable. And then the next process is about creating Sarika, could you please go to the previous slide? Yeah, thank you. Oops. So that's the last phase of the process, where you prepare an annotated report, and in the annotations you add like footnotes and references, and the witnesses also helped us in getting together the text of the annotations and also the references. Sarika, you just have to move to the previous slide, please. Sorry. Yeah. Thank you. And then once the annotations is completed, and we change it into we transit to a report format where we add the backend and the front end and send it to the witnesses for a final approval, and then it is and then we prepare it for publication. And then next slide, please. Thank you. So you will see, Sarika, if you click, so this is a screenshot from the second witness seminar we had. And then you will see with the next click, the 2 of the reports that we have published online. And these are available on our website. And then next, Sarika, if you click, you will see the analysis process that we've used for the transcripts, which is, so we have coded the transcript using the Atlas TI software. And we had prepared a few predefined codes based on the guiding questions across the themes that we had decided on, that is the emergence, evolution, and impact. And we have segregated this analysis into 2 sections. First is emergence, and second is evolution and impact. And for the emergence section, we have used John Kingdon's multiple streams framework. And you will see that we have adapted the framework a bit to sort of suit our analysis. And you'll see we have framed all the findings and all the content from the seminar into the 3 streams of Kingdom's framework, which is the problem stream, politics, and policy, and finally policy output. And alongside, you'll see policy window, policy entrepreneurs. And we have added an extra dimension to this framework, which is you'll see at the top left, which is historical background. That is a legacy of community participation, something that we felt was very integral to sort of the entire process, and also analytically also to the other streams. This part and the content of it was very integral. And for the evaluation and impact section, we are doing a thematic analysis, which sort of follows a chronology. And if you go to the next slide, Sarika, you can just click all the sections together. It's okay, so that everything gets displayed at once and I can go through everything together. Thank you.
I also request you to speak a little slowly, please.
Okay, sure. Sorry. Yeah, okay. So in terms of the findings, here are a few of the findings from that we found. Sort of segregated into all three themes of emergence, evolution, and institutionalization, and evaluation and impact. For emergence, we found that the legacy of rights-based social mobilization, India, and also the growing state and civil society partnerships in health that was seen in the 1990s influenced the ethos that informed the Community Action for Health framework under NRHM. And the Jan Swasthya Abhiyan, which was the India chapter of the People's Health Movement, had a very key role in mobilizing the civil society organizations across a few cases of violation of the right to healthcare. And these cases were later heard by the National Human Rights Commission. And this entire sort of movement and process pushed for integrating community action for health under the NRHM program. And then again, during the 2000s, there was a group of key government decision makers who enabled and opened up spaces for civil society members to actively influence and in design and implementation of NRHM's community participation frameworks and models. And in evolution and institutionalization, these community participation processes under NRHM foster trust, communication, and opportunities for collaboration between the community, health providers, and political leaders. This improved accessibility and quality of health services. And technical framing of health issues and information asymmetry, however, led to sort of skepticisms and misalignments between communities and decision makers and political leaders around the needs and capacity of communities and devolution of power. And in the years following the pilot, so this pilot project so the context is that there was a pilot of the community monitoring framework that was implemented from 2007 to 2009. But after a few years after the pilot was completed, this entire process actually experienced some certain uncertainties in terms of having financial and political support. In evaluation and impact, so the civil society does continue to influence the program's priorities through the advisory group on community action, and it has been able to sustain its autonomy despite the threats experienced. And by GCA, this was the body that was established under NRHM, and it consists of civil society organization members who are actively involved in designing and implementing the community-based monitoring and planning framework under NRHM. And secondly, one of the pitfalls has been that the sustenance of community action for health hasn't happened through transferring of ownership directly to community-based institutions designed under NRHM, but it has required the perpetual presence of civil society members and organizations as brokers to facilitate the processes. And some of the determinants very specific to India, like civil society, leadership, democratic spaces, space for diverse political mobilization, and states' civil society partnerships are actively linked to positive results that were experienced as part of designing and implementing the Community Action for Health project under NRHM. Sarika, if you could click once. So on the right, these are the quotes that we have taken from the transcripts, and they align with each of these, each of the findings across these three themes. Sarika, this last slide, you can just click everything at once and I can go to, thank you. Yeah, thank you. So in terms of impact and outcomes, the findings from this study are going to support the civil society engagement mechanisms, advocacy movement, UHC 2030 for advancing social participation for universal health coverage. And the design and methods that we have applied in this study are currently supporting and feeding into the larger, more global sphere project, which is also focusing on documenting and looking at social participation in health across 3 countries at present. And then we are also planning peer-reviewed journal publications, 2 of them, and we have and we are proposing it to be co-authored with interested witnesses. And these papers are currently in draft. And on the right, you will see a poster that we presented at the Health Systems Research Conference held in Bogota. And it is just a brief overview of the project and the methods that we use, and along with the findings. And that is the end of my presentation, with a few of the acknowledgement of people who really helped support setting up and bringing this project to the finishing line. Thanks to all of them. With that, I would hand over to Devaki. Thank you so much.
Thanks, Ms. Ami, for giving that presentation. I know it was a bit tricky with doing that, and thanks to Sarika and Saurabh for their help with getting our messages across. I think we now welcome Rajesh, and the person sharing their screen is Dr. Hari Shankar, who is a research fellow at the George Institute based out of the India office. And his area of focus is health systems and equity. He has a passion for primary healthcare, drawn from experience in disease surveillance, government service, as well as experience with implementation research. And he will take us into a deeper dive, looking at experiences not at the national level, but at the state level in Kerala. So over to Hari for his presentation.
Thanks, Devaki. So Ms. Ami has taken us through the process of conducting a witness seminar. So ours is a study that is based on the first 3 of the series. So the national ones are the 4th and the 5th reports, which is available for all of you. Ours is a study that we conducted from the first 3 reports, which was based on Kerala. So what we were looking at in Kerala, this is the 25th year of the decentralization reforms that has happened in Kerala. It started in 1992. So there was a lot of interest in understanding the decentralization, and it's well documented also. A lot of the participants of our witness seminar itself have done good
Hari, go a little slower. It'll be helpful.
Sure. Sorry, sir. Yeah. A lot of our participants have already published about decentralization efforts and its impact in health, Kerala. But that was from the period it started in the 1990s. So what we were interested is looking at a period where it is very less documented, and another flagship program, the National Rural Health Mission of the central government, had come, and how these 2 programs interacted, and what was the outcome that it had in the health system of Kerala. That's broadly what we were looking at. So just So yeah, this is the background of our study. So the constitutional amendments came in, the 73rd and 74th constitutional amendments came around 1992, which meant that local self-governments were established in every state. 3 levels of local self-governments were established, which had elections to be held, and these elections will have reservations for as members for women, caste minority, and tribal populations. So this was in 92. And in 96, the government of Kerala started something called the People's Planning Campaign, which they have devolved the functions, funds, and functionaries, and asked and made this local self-government autonomous in a way to decide the developmental agenda in the respective panchayats or villages. And in 2005, the National Rural Health Mission, the central government health scheme, was launched, which also had a very strong community health participation component. So these are the basic premise that we will be looking into. So what we were trying to look, as I said earlier, is that there is fairly good documentation of Kerala's decentralization process. So we were trying to understand what happened when NRHM was launched, and there were several community components in NRHM, and how did it help, and what was the synergy between these 2 reforms, and how it had an impact on the health system of Kerala. So the method is quite detailed. Ms. Ami had already gone through it. I will not go through that now. So ours, as I said, is first of the 3 of the witness seminars that was conducted. And again, this was also conducted through in a Zoom platform. And the participants were policymakers, public health workers, and academics who were part of this process. As we see ourselves, they were witness to this process, and they were part of this entire process of either being a member of an working committee or a implementer who done this these reforms, implemented these reforms in the field, or an academic who had written about this. So we then used something called a realist approach to look at this transcript, where we looked at what are the context in which the reforms were done, what are the mechanisms of how these reforms happened, and what happened out of that. So we characterized the transcripts. We looked at transcripts through a context, mechanisms, and outcome lens to better understand it. So these are our participants. As I said, there were senior health administrators, there were people who were part of NRHM. So now NRHM is called as National Health Mission. So we have, but when the time of the study, it was National Rural Health Mission. So that's why the R is in quotes. And there were elected representatives who were part of a witness seminar process, and medical officers who implemented the programs in villages. So there were total 16 males and 5 females who were part of a 3 witness seminar series. So we have, as I said, we have arranged this thing into context, mechanisms, and outcomes to understand it better. So as a frontline health worker has told us, when you give enough funds and functionaries and freedom to the local self-governments, that actually help to create innovative health solutions for local problems. Because people were able to identify what were the local problems, and they had technical help from people from the health department, and they designed programs, and the local self-governments had enough funds to implement these programs. So this, in this context, a lot of innovative programs came up in the state. So palliative care program of Kerala is one such innovation. So this was a context, and then when NRHM came in 2004, there was a community health component of NRHM. So they decided to incentivize and support this interest of local self-governments to invest in health. So they started something called a award, an Arogyalam award, for the best performing LSD, in terms of the LSD which has done an innovative program, was funded a best innovative health program. There was a process to identify it, and the award would be given by the Chief Minister of the state. And also there was a training program for the implementing officers to make innovative health programs using the funds from LSDs. So they motivated the healthcare workers and the local self-governments to invest more in health. This actually helped to sustain some of these innovative health programs that was launched, and also to again improve the innovations or bring in more innovative programs in the future. So what happened out of that is that, as a senior policymaker had said, the utilization of public health hospitals or the public health infrastructure has gone up in the state. So KSSP is an NGO in Kerala who have done a study, says in 2018, it was 28% of the people, but now almost 76% of the people are using the public health infrastructure in the state, which he feels is an outcome of the improvement of the public health infrastructure itself, is due to this interaction between NRHM and largely due to local self-governments, but with the support of NRHM. So this is one good outcome. So and another outcome that had happened along with this was that after many years, slowly some of the programs, for example, an example was the palliative care program. There was an innovative program which started in a small panchayat. The state understood the importance of it. They made it a policy. A state policy was introduced to include palliative care program in every, so that every panchayat in the state should implement this program. So they made it a mandatory program. So what happened with that is that the funding the window didn't increase much. So the funding almost remained same, and there is an innovative program, you make it mandatory that now every panchayat has to use it. So then you're going against the very idea that you have started off of, giving that freedom to decide on what you should do should be your own choice. So some of the elected representatives who are part of our seminars felt that there is a program of there is a tendency of centralization that is now going on as states decide what should be done at the local self-government level. And also people feel that a witness felt that the true nature of people's participation has been lost now over the years, especially after the introduction of computers for submitting plans LSG planning process, because now it is quite easy. You don't actually need a group of people to come together and identify problems. You just need a program plan which can be uploaded. So the two outcomes of the first CMO configuration. And the second CMO configuration is, we will look at it. Our participants felt that over the years, like it started in 96, by around 2000s, the momentum of the decentralization has been settling down. And then people started losing a little bit of interest in this. And then it was a time of the pandemics in Kerala, like the pandemics and the epidemics started coming. The chikungunya came in at somewhere around 2000. Then there was Japanese encephalitis, dengue, and then COVID came in, there was Nipah outbreak. So when all these disasters happened, it reanimated this interest for community participation in health. And the local governments were very at the forefront of managing these pandemics and epidemics in the state. So this brought together the health department and the local self-government together, and actually created structures, ward level structures at ward level, which would be key in conducting all these disease control activities. So the role of NRHM here was that NRHM already had a strong community health component. So they had funds to sustain these kind of structures at a ward level, the WHSNCs or the ward health sanitation committees. So the platform was there for local self-government members, ASHAs or the community health workers of program of India's National Rural Health Mission. So all these, the platform was raised. There was a platform for all these people to come together and plan to work together to mitigate the impact of the disaster. So this again helped in having a better disaster response to the disaster response by the state. So a medical officer tells us about an incident where the mass drug administration program is one of the neglected tropical disease filariasis. They were able to achieve a good coverage of mass drug administration program because there was people's participation and these ward level structures were very strong. They could have a better coverage for this disease. So the disease control program is benefiting from this interaction between local self-government members and community health workers at a grassroots level. As I mentioned earlier, there is an unintended intended outcome. So there was elected representations. Elections were held at local self-governments at every level, and female participants. There was a reservation for women. So the ASHAs in Kerala, some of them now elected as elected representatives. Because they are working closely with the local self-governments and are known in the community, they become a natural candidates for community or the ward level positions. And as an NRHM official has said, 746 ASHAs contested in the last local self-government elections, and 113 of them are in a leadership position, either a health standing committee member or a panchayat president. So this has fostered kind of female leadership at a very grassroots level in Kerala also. So coming to the conclusion, we find that largely this interaction between the National Health Mission and local self-government, the decentralization efforts have improved the health system of Kerala. It has also helped the state to have a better disaster response and better to build a resilient health system. So you have a very strong structure of autonomy at grassroots levels, and a very strong relation between the local self-governments and the health workers and the community. So yeah, that's it. Thanks.
Thank you very much, Hari and Rajesh, for this presentation. We will now move to the next part of the proceedings today. And therefore, it's my pleasure to invite the host of our fireside chat, Professor David Paris. Professor David is acting chief scientist at the George Institute globally. He directs the global primary healthcare program and is co-director of the Center for Health System Science at the George. Apart from this, of particular relevance to us is that he leads the Sphere Consortium on Social Participation for Health on behalf of the George. Apart from that, he also does a lot of path-breaking implementation research and mentors many of us. His bio is quite long and impressive. Shraddha is just pasting the Sphere website and you can check out more about his bio there. I'll hand over to him now to lead the fireside chat with 2 housekeeping requests. One is, if you have joined us as a listener, as a participant, please mute yourselves for now. We'll have a Q&A section later. And second, please try to speak a bit slower for those of us who are speaking so that we can communicate clearly and effectively. So thanks. Over to David, please, to host the fireside.
Thank you, Devaki, and thanks, Hari and Missimi, for a fantastic presentation. I really enjoyed hearing the work you've been doing, and I think it brings us nicely into the next section around social participation in health and some of the work we're focused on in the Sphere collaboration. So we have 4 speakers, and I'm very excited to hear their perspectives on these issues. First up, we have Smita Sadasivan, who's a disability rights practitioner, and she's a member of the Civil Society Engagement Mechanism for UHC 2030, and she also serves on the steering committee of UHC 2030, and also has a very impressive bio, which I don't have time to read through right now, but please do go to our site to hear and see more about Smita's work. Next up is Justin Coonan, who is the co-chair of the UHC 2030 Steering Committee. He's based in Sydney and Australia, and is the president of the AIDS Council of New South Wales. And we're also very excited because Justin has recently joined us at the George as a distinguished fellow and professorial fellow, and it's great to be working more closely with Justin this year. We then also have Nguyen Toi Lin, whom I've been having the pleasure of starting to work closely with through Sphere this year, and Lin is the Deputy Director of the Centre for Supporting Community Development Initiatives, or SCDI, in Vietnam. And last but not least, we have Dr. Abhijit Das, who is the founder and managing trustee of the Centre for Health and Social Justice in India. So 4 great speakers, and we have about 40 minutes of your time. And I just wanted to introduce you to my friend here, Froggy. Froggy is a very attentive listener, but starts to get quite impatient after a couple of minutes. And at about 3 minutes, will start croaking. So that's your time to give up on speaking and hand over to the next speaker. So with that, I'll just open with a question. I was reflecting on today, another meeting. A speaker was talking about the National Health Assembly movement in Thailand, and I'm sure many of you heard about the foundation to that, the triangle that moves the mountain. The triangle being knowledge mobilization, political involvement, and the third key one being around social mobilization, and being a really foundational piece for the reforms and progress that Thailand have made on universal health coverage. So I guess what we're talking about here is that third point of the triangle around social mobilization. And perhaps I'll start with Smita first, and to hear your thoughts on why is social participation for health important for universal health coverage. So over to you, Smita.
Thank you very much, David. So it is very important because the social participation enables formulation of UHC programs from the perspective of people themselves, like from the user's point of view, and that can only happen if there is social participation, and we can actually know about it from the representations that Hari and Missimi made. And when you look at the government looks at it on a macro perspective, like from the bird's eye view, that to reach out to majority and to serve more with numbers. Whereas when you look at community groups or social participation groups, we look at it from the micro perspective, and we are looking at in-depth details, which as a person with rare disease myself and a person with disability, it works out so much for me personally, because where I can see community support is at the social participation aspect, and not really at the macro program. And so to ensure that community support systems get evolved around health, and for that only social participation is key.
Thank you, Snitha. That's a great opening to this. I might move now to Justin to hear your perspectives.
Thanks, David, and great to be here, everyone. Thanks for those excellent presentations. Probably everyone here has their own ideas about this question already. You've probably thought about it. I might focus on the equity aspect of social participation, and to make it concrete. When COVID broke out in early 2020, very soon after, the UHC 2030 civil society engagement mechanism surveyed civil society organizations across the world, about 200 organizations in nearly 60 countries, asking to what extent they had been involved, or civil society in their country had been involved in planning the national response. And there were some bright spots, but broadly, the implementation had taken place without the input of civil society. And we saw the direct impact of that happening in a pandemic. And put very simply, if we want to, as the UN Sustainable Development Goals call for, to reach everyone and to reach leave no one behind, you need to be able to plan health programs in the language, not just the spoken technical language, but also in the culture of the people who are going to be accessing these services. If you want people to use health services, you need to create demand for those services. And that means responding in culturally appropriate ways. And centralized responses typically do not do that. So if you want to reach the most marginalized and most vulnerable people, you really have to understand that perspective. So I guess I have three very brief answers. The first is simply an equity answer, that we can't leave people behind. The second is a broader answer about what governments have committed to, including at the high-level meeting on UHC in 2019, and that is to provide health services to all of the people who live in their countries. You can't do that if you are not taking into account the most marginalized and the most vulnerable. And then thirdly, as we saw, because of how interdependent all of our societies are, both within countries and between countries, something like a pandemic will focus on the weakest link. And so that if you actually leave particular groups behind, you're in effect leaving everyone behind, because we're all connected. And no more time to speak in greater depth, but literally everyone's lives depend on engaging the people who are sort of furthest from the center of the health system. And that's where social participation is particularly critical. Thanks.
Thank you, Justin. We might move on to Lynn now.
Thanks, David. For me, the social participation in health is critical to help us to achieve the universal health coverage. In Vietnam, when we talk about universal health coverage, most of the time people will say, okay, it is like 90 or 90% of the population have got the health insurance. But for us at SCDI, we don't think it is enough. I very much agree with our colleague that it is not just about reaching many people, but we have to reach those who are most in need of healthcare and have the most difficulties in access. And universal health coverage needs to reach the furthest first. And we need to ensure that inequalities or disparities are not barriers to quality healthcare. And literally, we need to leave no one behind, whether they are just people of the minority, the young people, the children, or some members of the community in remote areas. So that is the meaning of social participation to help us reach the universal health coverage in the most universal way and really leave no one behind.
Terrific. Thank you, Lynn. So I think an emerging theme in all of the three responses so far. The baton is to you, Abhijit.
Thank you, David. Thank you for the presentations and for the interjections. First and foremost, I'll go back, I'm a little gray. So first of all, I'm now hearing social participation. I grew up hearing community participation. Now, what we have to realize is, and this was also highlighted in the presentations, is that we have to go back a little to history, a little to context, to emergence. So participation is about 50 years old. Around 2000, participation was being universally acknowledged, and there were these experiments that we discussed, which are, we are 10 years old at least. We are today in a situation when participation actually is under stress and challenge in various ways. So while the policy rhetoric is very strong, even in these studies, we find that actually on the ground, things have gone back. So number one is to recognize that just saying participation is not enough. We may end up with instrumentalizing participation, which has happened in the past. So to make participation substantive, to actually address health equities, we have to recognize the political scenario, the mobilization that we were talking of, and the ability to negotiate. Without negotiation, we cannot move into this democratic participation framework, which I have been very much closely sort of involved with the NRHM thing. It doesn't exist anymore, what was existing in 2006. The second thing that I would like to say is that in order to bring everybody in the inclusion framework, we have to recognize that every day there are new forms of exclusion. Older groups, as they get recognized, also become empowered. We have to find ways in which empowered groups not only stand for themselves, solidarity is provided by everybody to empower excluded groups of the past, but new forms of exclusions are identified and included and empowered. That's the social mobilization challenge, because what has happened today is the world is becoming increasingly sort of fragmented on identity politics. If we do identity politics, give further strength, there will be fragmentation and new forms of exclusion we may miss them. So we have to be careful. Just an example, immigrations are taking place in country and international, new kinds of urban disadvantages are happening, which were not necessarily recognized politically earlier. So we need to realize that. And the third thing I want to say is that just rhetoric is also going to be important, because we need to push to keep the space open, because governments across the world, international rhetoric may go in one way, but if you look at many national governments, they are actually tokenizing participation. So whoever gets a space in the door to be in the in a policy framework space must find ways in which they keep the flag flying and they include more and more people into that group, so that we don't become individual brokers of participation, because the government would love to have individual brokers of participation and bring them, as we call them, co-opted. So while participation, I repeat and acknowledge everything that has been said, I just want to raise a cause of concern, is that it's becoming it's becoming every day, so it's losing its edge, and governments are also not very keen to provide that edge. Thanks.
Thank you. Yeah, that's a very nice segue, I think, into our next section of this chat, which is, and you've touched on it already, Abhijit, that the kind of lessons learnt from the past and how they might inform the response today. So I might just try to go into that a little bit deeper in this next segment of the chat. And back to you, Smita, in your career and in your experience, in your lived experience, what have been some of these key lessons that we need to bring to the forefront and make very dynamic, as Abhijit was just mentioning, in progressing the movement on social participation?
Yeah, thank you very much, David, for that question. So I would like to give a couple of examples from my own experience, like as being part of the disability movement of Tamil Nadu, we worked with the disability department and also the local implementing authority, which is the Greater Chennai Corporation, and enabled that we have sign language interpreters at the helpline, at the disability helpline, so that people with hearing impairment, whoever is deaf, can also get the information on COVID and also on other support systems. So that was possible only because there was a willingness from the department to engage us, a willingness for social participation, and it really helped. And also we worked with the authorities to ensure doorstep vaccination for people with disabilities, people with rare diseases, and also their caregivers, because the caregivers cannot leave the persons behind at home and go out during lockdown and whatever. So these were all some examples of social participation which happened due to social participation. And myself being a member of Multiple Sclerosis Society of India Chennai chapter, I know that there are cases like a few of our members are living together, and when they are stuck without a caregiver and are living alone and on the 4th floor in their apartment and could not come down, and all are wheelchair users, then they could immediately reach out to Multiple Sclerosis Society and ask for whatever they need, like their food or even diapers or medicines. So all these things, this makes the community support, which is not really provided by the government. So what the government should look at is to enable the community support system, which can be possible only when there is social participation. And if there is no social participation, what will happen? That also I would like to just give one example and end. There are cases where people with psychosocial disabilities, one incident happened in Kolkata where due to COVID, all the OPs were closed and they could not get their medication. So because of lack of medicines, people started becoming violent, having behavioral issues, and their own family members killed the own brother killed the brother with psychosocial disability, thinking that he might harm others. So the right to life itself is in stake if there is no social participation. Thank you very much.
Yeah, thank you, Smita. I guess moving, Justin, you talked earlier about some of the responses and the partial responses to more equity promoting policies during the onset of COVID-19, and the sometimes the inability of centralized approaches to really understand the equity issues on the ground. And I just, again, drawing on your long history in this space, perhaps some of the areas where you've seen examples of best practice in social participation, and maybe some of the outcomes that have come from that.
Yeah, I think we have some very recent past to draw upon and learn from. And so if we take it as a given that social participation is important, and in particular, I guess what I mean by that is the institutionalized processes for engaging communities and civil society in national and subnational and so on, health planning processes. If we take that as a given, one of the prerequisites for those kind of processes to work is the building of trust between communities and governments. And the really big lesson, I think, from COVID, or at least one of the big lessons, is you can't build that trust in the middle of a crisis. Or you can, but it's very difficult. These things need to be set up well before, so that the trust is there and you can lean on it when you need it. Some countries had that, most did not. And I'm really pleased that you brought up the example of Thailand, because of course Thailand is one country which is very often sort of rolled out as a gold standard for social participation. And I mean, we may have some things to say about no country is perfect, but it's certainly true that the National Health Assembly provides a really good model for what social participation looks like. But there are others. There's Démocratie Sanitaire in France. There's the National Health Assembly of Tunisia. Iran does some really interesting things. So there are countries where this has worked in a more developed way than others. And I would probably like to call out at this juncture some work that's been done on this by the WHO Social Participation Technical Network in developing a handbook on social participation for UHC, which speaks to these issues, excellent examples, but also some of the key challenges in considerable detail. And so I'll put a link in the chat if people haven't seen that resource, but I think this speaks to some of the issues from the past really effectively and what we can learn from them. And then the next question is, okay, so we understand the theory, but how you operationalize that? And I guess that is to some extent what we're trying to do through the sphere process. So I'll stop there, but maybe we can come back to some of these discussions later. Thanks.
Yeah, that'd be great. Let's move to Lynn again. Particular experiences in your career around best practice in social participation, or indeed, as Smitha brought out, areas where if it is neglected, some of the consequences of that.
Yeah, every time we talk about social participation in health in Vietnam, we remember the story of the HIV response. It is the movement of the people living in HIV in Vietnam, which has been a very inspiring and typical example of social participation. And now it has expanded and inspired other communities to start their participation in health. You know that like more than 20 years ago in Vietnam, there was no ARV treatment. It was introduced in Vietnam only in 2004. And at that time, people living in HIV with HIV were still living in huge stigma and discrimination, and having HIV means you will be sentenced to death. However, 2 years later, with the passage of the HIV law in 2006, there's an official recognition and the legal framework for the participation of people being affected by HIV in the national response. And the community has a national platform to engage and to participate in the development of policy, and the policy makers, they come to listen to them and take their opinions into the policy making process. So 20 years have passed, and now that process still goes on through years, and now the HIV services in Vietnam is very well rounded, with ARV treatment available in all provinces across the country. And HIV screening tests and referral is provided by hundreds of community-based organizations, and the cost of ARV treatment is covered 80% by the health insurance. It is a big win of the community of people being affected by HIV over the disease, as well as their fight to be able to participate and to be a part of the HIV program, of the health program. And now the organizations of key populations are playing crucial roles in all aspects of the HIV program, the whole spectrum of the program, and they continue to advocate for better policies for other health issues. So that is a story that we always remember when we want to develop the community and engage the community to advocate, as well as to develop good health policy. And now that spirit has been brought into other areas like malaria, tuberculosis, and also other NCD disease. We realize that the community has a very immense potential, and with their participation, we can develop better policy that can bring the benefit to many Vietnamese people. And we are very happy that the policy makers, they also learn from that lessons from the HIV program, and now they start to engage with the community more and more. And in Vietnam, it is although the civic space, it may shrink sometime, it may expand sometime, but we can always find a way to engage people in the policy making in the health sector.
Great, thank you, Lynn. I just wanted to maybe we can move to Abhijit on this to build on the conversation. Justin talked about one of the goals being around institutionalization in law and holding governments accountable. And that example you just gave, Lynn, around HIV and the outcomes that followed, and once this became enacted in law, and maybe to you, Abhijit, how important is institutionalization of social participation? We there's a continuum there from consultation, engagement, but this is really at the other end where we have it hard coded and hold people accountable for it. And in your experience, how important is that in this in progress and movement?
We, my experience is that we tend to see institutionalization as a holy grail. But my experience is that even after institutionalization is done, the foundations are eaten away as the political environment changes, as new kinds of political alignments take place in the country, because the normative that the UN or the international agreements have put up are being challenged all across the world. So while institutionalization is a huge victory, you have to keep working at keeping those institutions working the way they should. I am a member of the National Human Rights Commission. Does it mean that the National Human Rights Commission is working the same way that it did 10 years ago? Will it continue to work the same way 10 years later? I'm an advisory group member. So it changes just because there is a human rights. It's important to have that human rights institution, but you have to keep working to keep the mechanisms going. So that's one important thing about institutionalization. The second thing I want to also say is that sometimes policymakers agree to participation because they think the other approaches are not working. Participation will work. It is the new kind of shortcut. Now that will not happen. I remember talking to a policymaker who said in the most affected districts where what is called in India left-wing affected districts do social participation. Their trust is not there. For any kind of participation to succeed, you will need to make new arrangements. And I think Smita sort of gave examples of new service delivery arrangements are required. So you need new arrangements. For that, you need to go to the drawing board to find the consultative spaces of what people who are being excluded need. So it is not a shortcut. It can't be done quickly. Unfortunately, policy cycles and policy, there's a huge anxiety for success, and success all over the world in the same way. So that, we do RCTs, we have this hurry for RCT, so that you can then scale up. The point is, if you're going to look at small communities, if you're going to look at inclusion of those who have been, excluded for generations, who did not exist in your imagination, you have to give it time. You have to have patience. You have to allow those participants to join in and probably fail because they've never done this before. So that patience has to be balanced against the anxiety for quick results, the anxiety of aid effectiveness. Donors want results overnight. So that kind of, that's a huge lesson that we have. And an important lesson is, how do you do research? Because these research is an interpretation of community experience and putting it up into higher echelons of public policy. But if we have not learned how to listen to these people who were excluded earlier, we need to find new ways. Like this example of using witness seminars probably is a new way of listening to the witnesses, but how do you deal with the contradictions? And final thing is, we haven't discussed privatization. In a country like India, privatization is going rapidly. All over the world, privatization is now seen as a way you can't avoid. But how do you hold private sectors accountable? How do you have regulatory frameworks? How do you put the weakest of the weak in a position where they can ask questions from a very powerful private sector? Now, these are things that we have not really put on board. There are new things that we need to sort of lessons learned from things that we have done and things that also are emerging. I'll stop at that.
That's great. No, that's a nice summary there. And we might come back to some of these things because you've done very well. Froggy hasn't spoken at all yet, and we're doing well for time. And it might be good to bring some of these discussions back for a little bit at the end. But I guess the last part of this chat is around looking forward. There are a lot of key events globally and locally that we're keen to understand as opportunities, convening events, I guess, to take advantage of bringing out some of these messages you've all been talking to. So I guess the final section of this is really what's on your priority list for the next 12 months and beyond? What do you see as being perhaps kind of catalyzing events to really accelerate this discussion and bring to the forefront some of these key issues you've brought forward? And we'll go back to Smita again first off.
Thank you very much, David. So looking at the way forward, the key requirement is to have a systemic and effective social participation, which needs to be woven around the perspectives of the people, and it should not be tokenistic. It should be, really given weightage, and it should be discussed at the national level, at the international level, in all political leaders' discussion, and they should all come forward to do that. And so we are also trying to do this as a campaign. Right now, we have built a campaign in the name UHC for India, Universal Health Coverage for India, and we are trying to promote it. It is on both aspects. One is to give information to the larger public on UHC, what it is all about, and what is their entitlements and all that, and also to serve as an advocacy platform to reach out to the government, and they make effective mechanisms implemented on the ground level. And basically, if we look at it, health information is lacking. There are brilliant programs, like we have the doorstep medication program, but which has been announced, which is all in the website and in the news. Whereas even after a year of starting it, if you ask a lay person about how he or she can access that particular program, nobody knows about it. So we need, the health information is very important, which we have to really accelerate. And this should be enabled along with the community coordinators or community buddies. So the government can come up with some mechanism where there are coordinators in the community who can act as buddies, who can act as licensing officers, provide information, or can be approached when a lay person needs some health service, so and things like that. And also the government should engage with the civil society groups at all the levels, planning and decision making and implementing, because wherever the government loses its focus, it is the community groups who pitch in and make it available for people on the grassroots level. So it is very important that the government gives focus on social participation. And last but not the least, adequate budget is very, very essential. And as UHC campaigns are pointing out, it is never a cost, but it is an investment. So the budget should be allocated not only for programs, but also for social participation. Thank you very much.
Terrific. Thank you, Smita. We'll maybe just again move on to Justin, your priorities on your 2023 list.
I just want to call out something probably everyone in this call knows, but there's a high-level meeting on UHC at the UN General Assembly in September next year. In 2019, there was the first UN high-level meeting on UHC, and in many ways it was a great step forward, because it was the broadest ranging global agreement in health in history, whereas previously there'd been political declarations on particular issues. This was a much broader health agenda. On the other hand, it probably needs to get more specific and more concrete in terms of what countries are actually going to do. And also the world has changed because of COVID, of course. So we have an opportunity in 2023 at the high level meeting to secure hopefully more ambitious, more targeted, more focused commitment from global leaders. And one of the key demands will certainly be around social participation and the role of civil society and communities. So I would encourage everyone on this call to look for opportunities to participate in that process. UHC 2030 has an official role in the process through what's called the modalities resolution. And so we will be, and in particular in the civil society side from our civil society engagement mechanism, coordinating input through surveys, through consultations, through a multi-stakeholder hearing in New York, likely in April, possibly a bit later. So please look out for those opportunities, because the high level meeting is a really important opportunity for us to move forwards. And what we don't want to see is another agreement in New York or Geneva, in this case, New York, but those global political agreements which don't reach the ground level in Soweto and Sao Paulo and Mumbai are not worth the paper they're written on. So we really want to see not just a declaration, but a true implementation strategy. Please stay tuned for opportunities to get involved in that. Thanks.
And just Justin, on a follow-up on that, the World Health Assembly in 2024 is proposing a resolution on social participation. How might those two events connect, if at all, and what might be the momentum gathered from the high-level meeting that could be carried into the resolution that follows the year after?
Yeah, really interesting question. As you mentioned, 2024 is a little bit further away, but there has been indications led by Thailand for a resolution specifically on social participation at the World Health Assembly. I think the formal links between those two processes and how one will tie into the other are still being worked out, to be honest. But what we would hope to see, and I think we will take advantage of, is if there is strong momentum for the social leg of the triangle that you mentioned so appropriately through the high level meeting process. That is certainly going to help in 2024. To that point, I would say that, I mean, I focused on the high level meeting, but there's a lot of other processes going on in 2023, not least the G7. Japan takes over as chair on the 1st of January, and in some ways that's a fortuitous circumstance because Japan has had a really strong focus on global health as part of its international diplomacy for some time. And so there will be a strong push for UHC at the G7 and through the processes there. And within that, those involved are certainly pushing for social participation to take on a stronger focus than it perhaps has in the past. So I think the brief answer is multiple processes happening in 2023, including the G7, including the high level meeting. No formal links yet, but any progress we make in 2023 will certainly be helpful in 2024. And then, of course, I mean, no time to discuss all of this, but there are other important processes. There's a pandemic treaty that's being discussed at the moment. There is the Universal Health and Preparedness Review through WHO, which is a sort of a peer-led accountability mechanism based on the Universal Periodic Review of the Office of the High Commissioner for Human Rights, but in health. So there are multiple processes in which community and social participation need to be rooted. And we need to, yes, you're right, tie them all together, but we need to be alert in the first instance to all of these opportunities. Thanks.
Great, thank you, Justin. Over to you, Lynn. Your thoughts on priorities for the year and beyond, that looking forward.
Yeah, actually, the 2 years of COVID have slowed down the momentum in Vietnam quite a lot regarding the movement of UHC. So for us, our priorities would be to review rebuild and bouncing back stronger for the participation of the community as well as the NGOs in the advocacy process. And what we want to focus on building the leadership and champions in social participation in health, both from the community as well as from the health sector. The government of Vietnam has a very high political commitment to achieve universal health coverage by 2030, and we want to hold the government accountable of their political commitment. And we, like Justine just said, we will not waste any opportunity to participate and to take advantage of the opportunity to advocate, to not just have the better policy, but also make the policy work for the people.
Thank you, Lynn. And finally, back to you, Abhijit.
Thank you. I think all these efforts are important, but I'd like to also raise some caution. Number one is the number of international agreements have increased, but countries individually are also showing their own agency and not necessarily submitting to peer accountability processes. There's a lot of denial of civil society reports because sometimes they show countries in poor light. So we have to be careful about how much can be achieved only through international agreements. Things that would have been done, let us say, in the 90s and early 2000s, probably cannot be done anymore. The second thing is around COVID. I think COVID both tells us how, in this period, most governments used coercion and a lot of top-down planning. So that was one kind of shape of the government that the COVID opened up. But sitting from where we are in India, we also saw how, for people who could afford to pay for services, the health system was not able to deliver. So the health system, even the private health system, the much touted private health system, was very poor in its ability to respond to the crisis. What it means is that healthcare now, or the lack of healthcare now, is a universal concern, but it has to be made into a universal concern, because what is happening on one side, privatization, and on the other side, one-to-one cost exchange, like in countries in India, it is not a public issue. So how do we make health into a public concern, and not only for the poor and excluded? Because the poor and excluded do not have too much political voice. So in sitting in a country like India, we have to find ways for building new allies, solidarity allies. And here we have to be balancing between identity-based pressure and solidarity-based pressure. The second thing is, how do we get non-traditional groups into the development space? Because if it is only international donors, if it is international research organizations, it is international UN organizations, it becomes a small exclusive group, which actually has nothing to do with the private sector, who in a country like India is becoming the biggest determinant. So we need to find ways to bring these other allies, other players into the health conversation, so that the spaces that are opening up, the rhetoric that has been provided through leaving no one behind, can be given, an additional push. Because otherwise we can do things that we have been doing for the last 25 years, but the direction will move forward a little in some direction, and in some it will slip back. And we can keep sort of patting us on the back because new groups are included. But health inequities, if you look at the global data, a lot of progress has been made, but inequality has been increasing. So new groups of sort of excluded people are being found. The difference between the experience of the most marginalized and the experience of those in positions of privilege, those experiences are completely different. So we need to find ways in bringing these closer together. Thank you.
Yeah, great. It's going to be challenging to summarize these things, Devaki, but I'm going to kick off and then maybe hand to you on any key messages that struck you as important from this discussion. And also, if there are any burning questions or comments, please do put them in the chat so we can bring them up, because we still got a little bit of time left. But I think some of the key things that have come up for me from this discussion I think, Smitha, you started talking in your opening remarks around I guess the inability of centralized processes and governments and institutions to really capture the micro level perspective that you brought up, and that becomes a critical voice that is missed out, and pulling in Justin your points around leaving no one behind and the equity domain as being a key driver of social participation in health, that if those perspectives and voices aren't prioritized, they easily are diluted in the wider discourse. But I think also some of the points, Abhijit, you brought up was that equity is a dynamic concept. It's what we may consider to be priority groups and equity considerations at the start of a movement can rapidly change, and so it's an ever evolving concept and needs to never be kind of taken for granted. And as you highlighted in your last comments, some of these gaps are widening and accelerating at a pace that means the response needs to keep in touch with that. I think we also had a really interesting discussion around institutionalization of social participation in health. Yes, it's a critical lever and an accountability lever, and we heard at the global level the activities that are going on and are coming up to do that. But we also heard of the challenges of operationalizing that, and also the suggestions that these now may be becoming convenient tick box exercises to make sure that the social participation angle is covered, that the voices in the room are listened to, but not necessarily translating into action, and therefore there's a very ongoing, again, dynamic piece of work to look at the operationalizing of these processes, even when they do become institutionalized. And then I think some of the other discussions around, I guess coming back to that micro level point was that, and we heard from, I think, Miss Imi and Harry's presentations around the slow grind of the processes that happen at grassroots level. And it's not necessarily a case of, as Abhijit, you said again, this idea of we do something in a pilot context and then we can scale. But actually these movements have very dynamic processes locally. Yes, there are learnings, and you talked about that equilibrium between individual identities and solidarity. And I think, again, how you bring these local movements together, and that's definitely a core challenge for us in the sphere collaboration, is we're learning a lot from local movements and trying to kind of abstract up the knowledge of how that can be usable knowledge in other contexts. And the witness seminar methodology is one very exciting, innovative method to be able to capture that. So I think there's sort of maybe some of the key take homes I get from the discussion. I might hand over to Devaki for any other thoughts you might have, and maybe from our speakers, any final words before we wrap up.
Thanks, David. I'll make two, perhaps not new points, not two, three, 3 points that may not be actually new. And again, we're sort of reflecting on what has already been said. I think my distillation of what some of the comments have been about the HIV/AIDS movement, for example, the presentations about what's happened in India, there is a tendency to have some sort of nostalgia about that, and surely very important to learn from them. But as has also been raised by our panelists, times have changed, so really recreating or in their entirety duplicating those kinds of mechanisms is not may not yield very the same results, really. So whether it is trying to recreate the HIV movement for another kind of issue area or something like that, times are different, the situation is different. but there are critical lessons in those histories that are a starting point. Second, I think the opening up of participation, the way that Smita had talked about it, and the institutional opportunities that exist, the way that Justin had mentioned, I think we have to operate on multiple levels, certainly, and be nimble about those. And it takes maybe different kinds of groups and formations to do that. You know, that diversity that I think was also raised in the initial comments by Lynn and Abhijita also in their initial statements, that it has to be a multi-track kind of process really stands out to me. And then for us as the George in thinking about sphere, and this is my third point, I think it's critical to be quite reflexive about what are the roles of each of us different types of stakeholders. What can we achieve? What will not be possible for some of us to do? And where can we lean strategically on our partners, on our friends, colleagues, and allies to move this work ahead so that we can operate on all these levels, so that we can be mindful of, but not try to replicate history in new changed circumstances. So those were some of my quick thoughts. But I'd be keen to hear, we have a question from Dr. Anthony, if any of our panelists would like to take that on. He says, who represents the marginalized and poor in the limited space given for participation in health governance? That's an important question. How do you institutionalize effective participation? There's an easy question for you all.
So, yeah, so when we mean effective participation, it cannot be tokenistic, and it has to be built into the policy itself, number one. And number two, there should be respect for all the stakeholders, including the people's movement, because we also come with a great set of knowledge, and that comes out of the lived experience, as well as working with our own communities and at the grassroots level, which needs to be respected and accepted. So if the government, the leaders, not just go and give promises or sign the declaration and come back, but really take it up, and really engage with people's movement, then I think it will be good enough to a good start of social participation.
Terrific. I think I'll just thank our four speakers. It's been a great coverage of a whole lot of great issues for us. And I think, yeah, as you said, Devaki, for the Sphere collaboration, a whole lot of interesting themes have emerged from this that are priorities for us as a new collaboration moving forward. So I very much appreciate the conversation, and I'd just like to give you all a virtual applause. And I think we're handing over now to Deepak for some closing comments.
Thanks, David. I am Deepak. I work with the Institute of Public Health, Bengaluru, presently associated with the field station in Chamarajanagar, where we do work on equity. When I started my career, this community monitoring or community-based planning and monitoring of things was a new concept that was coming out. I understood it from a very simple point of view. It's like you have the routine information coming into the systems through your HMIS, which the system monitors. And there are external surveys which talk about what is really happening on the ground. So this community participation was brought in as a third angle to identify and accumulate data to improve the health systems in the form of feedback from the community. And it was institutionalized, and I mean, from the rich experience and talking to people who have been involved in, I can talk about it, but this is not the right time to do it. But what I understood, it is like a third way of improving the systems through feedback in a democratic manner. So that's it. And I'd like to thank everybody who has participated here, Mr. Abhijit Das, Smita Shivadasan, Justin Konin, Nugen, Harishankar, David, Rajesh Manoharan, Saurav Roy Chaudhary, and Health Equity members, Health Equity, any network group members, and communication team of George Institute of Global Health India. Thank you, one and all. Thanks.
Oh, we ended right on time. Thanks, everyone. I think for many of us, your weekend starts now. All right. Take care.
Thank you. Justin, nice to see you.
Yeah,
Closing the meeting.
And everyone.
Thank you.
Thank you.
Bye-bye.
Bye.